Hello, everyone. Today is November 27th, 2022. My guest today is Hussein Rassoul. Hussein is an orthopedic surgery resident. Thanks for coming on the podcast, Hussein.
Of course. Thanks for having me, man.
You're welcome. So, we were talking before this about how the younger generation of doctors is moving towards salary-based and employed with hospitals compared to the older generation, which were more private practice.
Yeah, I mean, I think even before my generation, there was always a mixture of the two. But I think that, there is just a generalization that private practices are dying for, I think, a multitude of reasons. I do think that my generation just likes security and security that hospital employment gives you. Because if you're private practice, your salary is based on like what you can produce, right? How many patients you see, how many surgeries you do, etc. Whereas the hospital just kind of gives you a basement that you're never going to really fall below. So I think that just more attractive to our generation. I feel in certain, and it's interesting because the people who go into medicine are not. They kind of like the safetiness of medicine. It's kind
Yes.
of it's a safe field, right? You're gonna get your employment it's not hard to get a job as a doctor, at least somewhere, right? So you're always kind of employable, and you're gonna have at least an upper income, or upper middle class income. So it's quite a safe job. So that I think now it's kind of attracting us to that hospital-based employment. But there's also market pressures that have forced these types of situations too. It's just insurance has become incredibly more complicated, so you have to hire teams in order to get your reimbursements from insurances, and payment models are just favoring large groups or groups of people or hospitals in general. And so being that person who owns their own practice has become less lucrative over time, which has played a role in kind of the death of the private practice.
Okay. And when you say have to hire a group of people to handle reimbursements from insurance, is that the hospital?
It's administrators.
Say that
So
again.
it's administrators, right? So
Okay.
someone is just dealing with the finances of it. Often the doctor just doesn't have time to argue with insurance constantly, even though we do at times. But it just often there's like, oh, I need this piece of information that you didn't send, and you didn't send this piece of information, or you didn't put this in your note, so therefore it doesn't qualify for this. And there's just a bunch of rules, and you kind of need a team to kind of streamline it for you, because it wouldn't you'd be doing more paperwork than treating patients, which is what we're already doing.
Okay. That makes sense, because if you want to be a private doctor, you kind of have to become a business owner, and the business of medicine is not very simple
It's
in the
not simple, and
USA.
it's not simple, and it's constantly changing, right?
What's changing about it?
Well, I mean, over the last 10 years, we've seen with the Affordable Care Act. I mean, that changed things, right? And I feel like our politicians are not very they're not very stable when it comes to healthcare, even though it kind of has been stable for the last, since probably 2010. But nonetheless, like, we're physicians are always nervous that things will change, right? No one likes volatility when it comes to their business. And it does seem like it is a topic that is discussed a lot in politics, and therefore is prone to volatility if the legislature is willing to do so.
That makes sense, because even things, something like Roe versus Wade, that wasn't even really talked about, and then all of a sudden that changed very quickly. Like,
Yeah, and it
and
completely and
we'll
it
go.
Yeah, and I think you're right. And people don't really talk about the medical aspect of it too. It probably changed a lot of practices out there.
Okay, you're talking about what changed a lot of practices.
Like Roe versus Wade. Um, you know, a lot of with state laws changing kind of rapidly, doctors don't know the type of treatments they could do for people. You know, this is an overgeneralization, so you can't say, oh, this happened to all people, but there were definitely places where physicians were scared to treat people for certain things, in which because they didn't know where things kind of landed legally.
Okay, that makes sense. And if something were to change with insurance, that ripples, that's even more confusing because at least Roe versus Wade, you can kind of, there's a certain few procedures that you know are encompassed by that. But then with insurance, generally that, things can change all the time and people won't know.
Oh, things change all the time, and there's so many different insurances, right? And they could all kind of change. Like this insurance covers this, but doesn't cover this. This insurance pays better for this, but doesn't pay for this. They have a contract with this pharmaceutical company, so that's the like that's the one they'll pay for this patient. It gets very complicated.
What do you think about insurance in medicine?
Um, it's like it's kind of a necessary evil, but it overcomplicates the system in order to produce profit, right? So if you make a profit, if you make a process like like if you can't navigate a process and you're the person who kind of controls that process, you're able to extract money from it, right? So I think that's where insurance kind of comes from. I mean, like insurance companies are they don't they don't innovate. They don't really do much really, except for say yes or no to paying for things. So I think of them generally negatively. Um, but in our current system, they're necessary.
What about our current system makes them necessary?
Most people can't pay cash for their medical procedures. Yeah,
That's true.
it's quite expensive
Okay.
to go get your hip done, right?
And then insurance. But then paying a monthly bill to insurance seems more feasible. And then when you do need that hip to be modified or,
Whatever
you
the
know,
surgery is, yeah, insurance
yes,
pays for it.
then, okay, that makes
Well,
sense.
yeah, because most people don't save for healthcare, right? So it's kind of it. But I guess if insurance went away, would people start saving for healthcare? Probably, but that would be mostly well-to-do people who are able to do that.
That's very true. Not, that's because a lot of the country lives paycheck to paycheck. So imagining them having to deal with, a sudden injury would be very, very, financially burdensome for for many people.
Yeah, I think it's the healthcare costs are the number one reason for bankruptcy in America.
Really?
Yeah.
Wow. When does healthcare seem to bankrupt a person? When they don't have insurance, or are there other ways it can happen?
Often it's when they don't have insurance, and there's often ways just like people, they have huge, just they have kind of shitty insurance plans, right? So it could be they just have large deductibles or large out of pocket maximums that they just can't afford. And you have to realize, like, throwing a lot of people over the edge is not as much as you think, right? Just being $10,000, a $10,000 bill is could throw a lot of people into bankruptcy.
That's very interesting. And yes, that makes sense. And I mean, that's not that much for an orthopedic surgery. That's very low amount for an orthopedic surgery.
Yeah, and a lot of it comes also from like practices in which your insurance won't pay for something. Um, so, like for example, um, if you get hit by a bus and you end up going to a hospital in which they are out of network, right? Your insurance company is only going to pay an X amount of money, and then the hospital is going to send you a bill for the rest of it, right? So that's where that's where a lot of it comes from.
Okay. Well. Making sure that you're in network.
Yeah, which is stupid, but yeah.
I always worried about that. I'm in San Diego, and I feel as though a lot of people here are within the network that I'm covered by. But we were talking about rural living, and there, this all out of network, in network seems like it would get much more burdensome.
Yeah, absolutely. It could get actually quite complicated because say you come in for a surgery, right? It's quite bad. But like, let's just say your surgeon is in network. There's absolutely been cases all over the country in which you don't know this, but your anesthesiologist is out of network. And so you get your surgery and everything, and then you end up getting a bill because your anesthesiologist was out of network and your insurance company is not willing to cover it.
Wow. And how much does an anesthesiologist bill without insurance?
I have no idea, but probably tens of thousands.
Wow. That's
overall, right? The anesthesiologist fee is probably much less than that, but there's a lot that goes into it: the medications, all the care that they produce, the use of their machines, etc.
Hospital has to have some fees too.
Yeah, exactly.
Okay. Wow. And so what do you think now? So you're year 3 into your residency. How has the last 3 years, have you changed? You started residency in the first year of COVID, correct?
Yeah, I did.
How was that experience?
Um, I think the brunt of it was experienced by my medicine colleagues. Being orthopedic surgeon, I was not as useful during that time. But you could see it in them. Like, my fiance is in the medical field, so you could see it in them, the burnout that they've kind of went through, the exhaustion that they went through, and not, um, especially, our mid levels as well, not just doctors, our nurses, you know, advanced practitioners and PAs, they're all burnt out as well. Hospitals are having an incredibly hard time filling in nursing needs. Actually, that's actually quite a huge problem all over the country, including at the best hospitals in the country.
Wow. And nursing is different than being a doctor in the sense of nurses can enter school right after high school, correct?
You could enter a nursing school. Yeah, yeah. It pretty
Okay.
much, yeah. But you still need to produce them, right? So it takes 4 to 6 years to produce a nurse.
Okay. That makes sense. But to produce a doctor, it takes how long does it take to produce a doctor?
It depends on what kind of doctor, but it's a minimum of 11 years
Okay.
because it's 4
And
years. It's 4 years of undergrad, 4 years of medical school. That's 8 years, and then the smallest residencies are 3 years. So that would be 11 years.
what do you think about having 11-year requirements for doctors?
Um, it's good and bad. I definitely think there's things that could be shed off of that time period. In Europe, they're usually you get admitted right into medical school. And so it's like a combined undergraduate and medical school that takes about 6 years. So you could definitely shave off at least 2 years there. But I do think that medical school is longer than it needs to be. I think that could be done in 3 years. The first 2 years are the way medical school is structured traditionally. Um, just as a caveat before I kind of tell you that, there are schools that are experimenting with different ways of doing things. So this is just the general way of how medical schools are done. Your first 2 years are mostly classroom based. So you're just learning biochemistry and pharmacology and the basic sciences, anatomy, physiology, things like that. And then your third and fourth year, you transition into clinicals. So your third year, like most medical schools, you take kind of the same rotation. So you do medicine, psychiatry, surgery, things like that. And we all kind of have like a core curriculum. And then fourth year of medical schools also, it's also a clinical. So you're doing clinical stuff, but it's more, you kind of, after your third year, you kind of figure out where you want to go. So it becomes much more like, I did a bunch of orthopedic rotations during my fourth year type of thing. I think that you can absolutely eliminate most of the first year of most of the first year of medical school, I think.
What's the reason?
It's mostly basic sciences. The reality is most doctors don't need to know a lot of basic sciences if you're being honest about things. And a lot of those things that we're learning were forced to be like prerequisites in undergrad. So like we learn biochemistry all over again in the first year of medical school. I don't think that's necessarily needed. It was a requirement in undergrad, so we kind of learned it. And to be honest with you, like no one uses the Krebs cycle during medicine, right? It's something that you could easily look up. It's not something that needs to be learned again and memorized.
Okay. What are things that are good to be learned and memorized?
Medications. So the thing is most of medicine, you can look up things, right? And as a doctor, you should be constantly looking up things. But obviously to be an efficient doctor, just like being able to memorize medications and their contraindications and knowing how to treat people with the correct dosing. And it's a lot more pattern recognition, right? So when you see a constellation of symptoms, you know that it's likely, probably one of these 5 diagnoses and how to get there, right? So it's a lot of critical thinking on top of a strong base of knowledge, right? So can you look up most things in medicine? You probably can, but you'd be a very slow doctor.
Oh, versus just having a little intuition about this kind of patterns that you saw in previous patients and applying that to your new patients?
Yeah.
Okay. It would be a if you just looked up everything, I don't think that's not a very I don't think that instills confidence in the practice.
No, it definitely would not still practice confidence in your patients. But I'd rather a doctor look up something than just make something up. So I don't think that they should. I don't think they should necessarily be reprimanded for looking up things.
Are they? Are doctors at times reprimanded for looking up things?
No, I don't think so.
Okay.
No, for the most part, I don't think they're looking up things in front of patients either. So.
Okay. Wow. So,
but often it could be like the things that doctors look up most often are like, oh, like this patient wants this medication. What's the generic form of that? I'll go look that up. Or I'm going to increase the dosage of this. Like, what's the next appropriate dose that I need to? So it's like little things that are mostly what people are looking up. And obviously, as you do it more often, you don't need to look those things up. You kind of just know them.
Okay. And that involves medication, do's and don'ts of different medications and, generic names of certain brands that the customer might bring up.
Yeah. And as a learner, as a resident, you're constantly looking up things, right? Because you don't have that knowledge base that the attending does.
Okay. And what is what does an orthopedic surgeon, how do they interact with their patient?
I think it just depends on the person and what kind of bedside manner you want to have. I think surgery in general has a culture of like paternalism and trying to like being very matter of fact. But I think that with kind of the commoditization of medicine and kind of being like a business person a little bit too, surgeons are becoming a lot are learning to have better bedside manners.
What
In
do you
order for
mean
their,
by commoditization of medicine?
I think a lot of medicine has become a commodity, and like you could leave like Yelp reviews for is not necessarily Yelp reviews, but you could leave reviews and things like that. So it's like become kind of like a commodity, right? And so, and people go shopping for their hip, you know, that's like a thing that people do. They like go see like 7 surgeons, you know, and like surgeons try to create like, you know, an experience to try to market themselves in certain ways now to try to attract patients. It's a business, just it's market forces, just being market forces, right? So,
Yes.
yeah, so those types of things. I think surgeons are kind of learning how to be better at that, and I think my generation is kind of it's just what is normal for us.
Okay. What drew you to surgery?
Um, so I always knew I wanted to go into medicine because I wanted to help people. I think that I wanted to help people and I want to interact with people. I was initially going to be an engineer, but I
I
just
don't interact with people. My
yeah,
job is
yeah,
best when I'm alone.
exactly. So like I was like, you know, my first year at UCSD, I was an engineer, but I was like, it's just too much coding. I like want to like talk to people a little bit more than this. Um, so I wanted to help people, and then I got into medicine, and then it was mostly like, to be honest, it was like the ability to diagnose a problem and then immediately help them. It's kind of like this instant gratification type of situation. And like when I shadowed people, like people love their orthopedic surgeons. Like we're the people that like can help you get rid of your pain and kind of like let you live the life that you want to live. And so like just seeing how much they appreciated uh their surgeons, I was like, that looks nice. That was the feeling that I was looking for, and I found it. So that's kind of why I pursued it.
Wow. How quickly after surgery did some of these patients, feel better and start,
Oh, a hip
recognizing?
for hip replacements, like there are people who like wake up after surgery and they're like the pain is gone. Like
Wow.
that's how for some, yeah. I mean, it can be like 90, like carpal tunnel syndrome. Like one of the most immediate reliefs are, so when you have carpal tunnel syndrome, one of the most like annoying things is nighttime pain. You just have a throbbing nighttime pain in like in a distribution in your hand, and when you have surgery, like that almost goes away immediately.
Okay. What is the surgery to fix carpal tunnel syndrome?
So carpal tunnel syndrome is it's the result of compression of a nerve that goes through the carpal tunnel, which is it's the carpal tunnel is, there's a row of bones at your wrist, and then there's a ligament that's on top of it, and you cut the ligament. So now you just create more space, decreasing the pressure within that area.
Wow. That's pretty simple
Yeah,
surgery, right?
it's yeah, it's a very very fast surgery,
Okay.
but it's great for patients.
Wow. That's
Yeah,
amazing.
yeah. Don't quote me on this, but I think that there was like a Lancet article. Lancet is like a very prestigious medical journal from England. It's like I think it's like their equivalent to like the New England Journal of Medicine, um, or like same kind of level of journal, and they like kind of ranked surgeries based on um, uh, like cost and like how much benefit it includes to the patient, and like and kind of like that kind of thoughts. So the number one surgery, I think, from what I remember, was cataract surgery. It was like the best surgery. It's like super simple, it's really quick, and you can help people see. I mean, that's pretty awesome. But number two, I'm pretty sure, was a carpal tunnel release, and number three was the hip replacement.
Wow. So orthopedic surgeons have two of the top three.
Yeah, I believe so. For me, don't quote me on that, but I'm pretty sure that's what it was.
Okay. And our carpal, I know the hip surgery is usually older patients. Is carpal tunnel usually older patients as well?
Yeah, in general, it's older patients.
Okay.
But I mean, it could be older and like they're probably older than 30 at least.
Okay. Not seniors, all of them.
No, no. Oh, no, no, no. Definitely younger than the people who are getting hip replacements, but you see it kind of throughout the age spectrum, anywhere from like 30 to, very old.
Okay. Wow. And so you mentioned the New England Journal of Medicine. Are there any other, journals or any other resources that you've used through your time in medical school and in your residency that have been useful?
Yeah. So in general, I do not use the New England Journal of Medicine very much. It's very much a medicine journal. So for the people who are pursuing medicine, it is the gold standard. It's the one where the best trials are in. It's the most robust research is in that. So people who are pursuing cardiology or like gastroenterology, just the medicine fields, that is their journal. We have
What do you
our
mean
own.
by medicine fields?
So I'm in orthopedic surgery, right? But there's the people who do internal medicine. So
Okay.
that is its own residency, and then from internal medicine you could specialize, right, into rheumatology versus nephrology versus, so like kidney doctors versus stomach doctors versus heart doctors versus lung doctor. Like that's all what we consider medicine. So like not surgeons essentially.
Okay.
um, that is like the New England Journal of Medicine is like the most prestigious journal there is for studies. I don't really read that very much. It's not really in my field. Sometimes there will be some orthopedic literature in there. Those are like pretty landmark studies that are very big and like multi-centered, and sometimes they get into those big journals. Usually we have our own journals that are much more specialized orthopedic. But nonetheless, medical schools, you're not really reading journals in medical school. You're mostly reading textbooks. You're mostly reading um, kind of things that are able to condense a lot of information into like short, chunks that you're able to absorb and learn from. So it's not really journals are very journals are scientific articles, and I'm sure there's engineering journals out there for the leading theoretical research that there is out there, but you know that it takes a while to read through those papers. It's not something that you could just quickly read. Like when I read a paper, it's like I would give myself like a good 30 minutes to 45 minutes to read just one paper, because you really want to understand it. You want to know if this is good research or if it's bullshit research.
Yes. And usually with these papers, like you can tell if what do you think? Like, can you tell if it's good or bullshit paper?
Sometimes, sometimes, especially because sometimes you just need to know the background of a topic, right? So like, and you can't hold the
Yes.
same standards across different fields sometimes. So like, if you're doing an asthma paper, there's just so many people who have asthma that you could do a large sample size on someone, right? Lance, a large sample size study, and that's kind of what's expected for something that is very common that you could treat in a kind of wide way. Whereas like something like let's just pretend like it's a spinal fusion for something very specific, right? You're a surgeon, you do like 7 of those a year, right? So it's going to take you a long time to create a sample size that is huge. But, at a certain point, you're going to have a sample size that is more or less indicative of like general trends, right? And that's important to know as well. It's not going to be something where you could say that correlates specifically with something, but it could give you an idea of something. It's weaker evidence, but it's evidence nonetheless.
Okay. And are these journals written by doctors that
Yeah,
so
for the most part,
okay.
they're doctors, researchers, sometimes PhDs.
Okay. And researchers are not doctors, but do they work with doctors?
They could be. There's research.
Okay.
There's research physicians, physician scientists, things like that. But often, like they're just people who work like with doctors. Kind of go, the doctor has an idea, and the researcher kind of goes through the data or goes through the records to accumulate the data to be analyzed, etc.
Okay. So we went to UCSD, which has it's a research heavy school and also has one of the top hospitals in the nation. So would UCS, like, how, I'm wondering, do hospitals hire researchers as well as doctors, or how do the
Yeah,
researchers get involved?
yeah, they will hire them. Obviously, if you're at a big medical institution, you have an army of undergrad and graduate students as well. I mean, you knew people in undergrad who wanted to go to medicine who just did free labor for people just because they wanted, to add that onto their resume, right?
Yes, many.
Yeah, yeah. So, so that's
Those are
part
the
of it.
researchers.
Yeah, those are researchers. And in certain ways, like it's definitely worth it for a lot of people to do that during undergrad. It actually gives you some real skills, whereas other parts of undergrad don't. So at least you're doing that. Um, and yeah, people hire researchers. People hire medical students. People. So it really depends on the system that you have. Yeah.
Okay. How do you think your undergrad education was in preparing you for medical school and in preparing you for, applying to medical school as well?
Um, Preparing me for medical school, I think it did a pretty good job. I mean, there's nothing. I mean, it did its job in that it taught me the things that I signed up for. And I do feel like I went into UCSD was quite competitive actually, and it was so big that you kind of had to rely on yourself and kind of your own grit to kind of force to do well. And so in that way, it kind of so you know it kind of is selected for a certain type of person to do well in that institution, and that is the type of person who does well in medical school, because medical school is not a place where people are going to hold your hand. It's somewhere where you kind of have to learn things you have to learn things on your free time. It's a lot of like self-directed learning, and the people who expected to have their hand held did not do well. As for like helping me get into medical school, I think I don't know. This was quite a while ago, so I don't know how UCSD now, but I mean, the resources compared to like talking to my colleagues, yeah, UCSD was like, it was not the greatest at like reaching out to students that were interested in medicine and helping them kind of create a CV that was competitive for medical school. It was mostly you did that on your own. With that being said, UCSD was so big that all the opportunities you needed were there. You just didn't know it. So it was just like there was a little bit of guidance and kind of helping you get those opportunities. I think you would thrive.
Okay. And that goes back to your first point where you never had your hand held through your undergrad experience, where possibly some of your colleagues you met in medical school, they were much more well directed by their institution. But
I think they were. With that being said, like all my colleagues were great and they all did very well. I mean, like if you get into medical school, you're going to be a smart person.
yes,
It's overly competitive to get into medical school. So the people that do get in, no matter what, they're all excellent people. They all care. So they're all going to do well. But it's a matter of like, at the end of the day, like no matter what field you're in, it's just like there's people who just have an easier time with it than that, and there's a group of people that just don't.
okay. And you just mentioned the word overly competitive. So one thing I would like to ask you is, what do you think about the number of doctors and how easy it is for someone to become a doctor in America?
I'll answer that. What do you think?
I think it's hard. I think it's too hard. And it seems to create a bottleneck of suppliers.
Yep. So I agree. I think that we constantly, so the real bottleneck is residency positions. And medical
What
schools
makes
could,
no
yeah,
go on.
I'll explain that in a second. Um, Medical schools can expand enrollment all they want, but if there's not enough residency spots, then It doesn't matter. And residency spots are in general funded through Medicare. So it's funded through the government.
Wow.
So it is the government really who determines the supply of doctor that is created. With that being said, it is overly competitive to get into medical school. I think that you have to be like you have to be you have to have a near perfect like college experience in order to get into medical school these days. And I do think, are we filtering out people who like would absolutely be good doctors? Yes, but we are selecting people who are really good and are going to become good doctors. With that being said, I do think that there should be more residency spots. I think there should be more doctors, more medical schools spots, and it shouldn't be as competitive as it is. I don't think that you need to like the averages now are insane, but like these people are you're scoring in like the 90th percentile of your MCAT plus like having a 3.8 GPA plus you need a few papers. I don't know why you need a few papers in basic sciences in order to get into medical school, but for some reason you do. So, I mean, it's gotten quite absurd. But the answer is not going to be to make at this point. It's not to make medical schools less competitive by opening up more spots. It's to open more residency spots, and then medical schools could open up more spots.
Oh, wow. Okay. And residencies are funded by the government?
For the most part, yep.
What's the reason?
I don't know the history of it, but I just know that is how it's done. Mostly it's because a lot of, especially early residents, are not, they're a hindrance to a hospital. You actually lose money. You order unnecessary tests. You're being taught. It's a training program. So why would a hospital rely on a group of residents that, one, may not make the money, and two, need constant training, and three, probably create more clinical errors, especially early in their career. So in order to incentivize that, the government funds it in order to create an army of doctors, right? Or else the market would say maybe having residents is not worth it, right?
Okay. For some reason, I don't believe that. I believe that I believe if the government didn't fund it, that hospitals would still be forced to take on residents.
Why would they be forced to?
Just because of the lack of available doctors.
But why?
And then
But why would a hospital care about that?
because then they could hire a resident for, well, the reason I say that is because I'm just thinking there's no doctors. There's not enough doctors. We have a shortage of doctors.
Mm-hmm.
Hospitals are getting more patients, so they need to supply more doctors. And then if residents were the only ones available, they would eventually have to hire residents, and they could do it for cheaper prices.
How could they do it for cheaper prices?
I mean, because residents will take cheaper salaries than an experienced doctor.
Yeah, but you have to train those. So the experienced, now you're putting the burden on the experienced doctors, right? Those people have to be trained.
Got it. Okay. And so that training is done by the hospital, correct?
By the hospital, the doctors, the AP, everybody. Yeah.
Got it. In industry, actually, one thing that's going on is that when an employer brings on an employee and trains them, and then say that employee gets trained and then leaves, that employee actually, a lot of companies will have something signed that says, if you leave, you have to pay us back for your training. And then they actually list how much that they have to pay back within. I don't know if that's a good thing.
That's a bad system.
Yeah, I mean, I wouldn't like that, but that's something that's going on with employers right now with the high turnover rates. But that's interesting.
That sounds like kind of like a non-compete in a certain way. I guess it's not a non-compete, but I don't know.
What's a non-compete?
A non-compete means that if you work here or you got a job here, you cannot get a job in this like geographic area.
Wow.
So certain places they allow that. I know California does not allow non-competes.
Okay, that seems I've never heard of that, but I don't like that.
It's very. I know like a lot of law. It's very common in law. I'm pretty sure.
Wow. Okay. Well, so residencies are the bottleneck.
Yes, for sure. I mean, if you think about it from a medical school perspective, they want to have more and more students, right? That's money.
Yes.
That's money through the door.
But residencies go.
Yeah, that's money through the door, like through like tuition, right? Whereas, but the problem is like as a medical school, you want to make sure that all your students are getting residency positions, right?
Okay, so you're not going to accept a bunch of students that might not get positions in residency and then have a low turnover rate from medical school to residency.
Yeah, exactly. It makes I mean, if you're in medical school and you accepted 1,000 people, but only 200 got residency spots, you're a pretty shitty medical school.
And nobody's going to want to come to you.
Yeah.
Residency, the way it's done is the way that medical students find out who they have matched with is unique. It's kind of like the sororities, the girls in college finding out which sorority they're getting into.
Yeah. To explain, the way it's done is through something called the match. The way it's done is, so you apply to a bunch of residencies. So like orthopedics is a very just the one I did, and it's very competitive. So the way you do is you apply to a bunch of residencies. You go on all these interviews, and they are interviewing obviously a bunch of people. And so let's just say I went on 15 interviews. I rank all of the places that I interviewed at, 1 through 15. And then all of the hospitals that I interviewed at also rank all of their applicants 1 through 60. Say they interviewed 60 people. And that's done for every single residency in the country for the most part. There's certain residencies that kind of do their own different match. And then on a very specific day, like usually in March, everybody finds out where they're going.
Okay. And then, so is there an algorithm, or how do the residencies coordinate that?
It is an algorithm, actually. And someone won the Nobel Prize for creating that algorithm.
Really?
It's a mathematical algorithm, yeah.
And they won the prize in mathematics?
I'm pretty sure. Yeah.
Okay.
Quickly look that up. Yeah.
That is amazing.
Yep.
What's it called? The algorithm? And who created it?
It's a matching algorithm. There you go. It was described by Roth and Peterson in 1999, I think.
Wow. And did he create it for the specific purpose of matching students into residency? I feel this seems like a universal algorithm.
I have no idea, to be honest with you. I don't know the history of it, but I do believe it's kind of it.
That's crazy. I mean,
yeah. Oh, here it is. Lord Sheppey, along with Alvin Roth, would go on to win the 2012 Nobel Prize in Economics for their work on stable allocations, which is what was used to create this algorithm.
Stable allocations.
Yeah, I don't know what stable. That's probably it's above my pay grade.
Okay. Wow. Economics algorithms to match students from medical school to residency.
Yeah, it's interesting. So
that's very interesting. What?
So stable allocations. It's a theory in economics. Is an allocation in which no individuals perceive any gains from further trade. That's what it actually means.
That, I mean, as long as that algorithm's running correctly, that's awesome, I think.
Yeah. Yeah, I mean, I think it's the most it's efficient, right?
Yes.
Because
And you can
the
never
alternative,
say like go.
the alter. I always like to think about alternatives because I feel like we live in a society that likes to critique. So the alternative of it is, I guess, just an open market, which in some ways would be fine, but it's just incredibly inefficient, right? So, I mean, getting a job takes forever in the normal market, right? So it would be like a lot of people applying, getting a bunch of like acceptances, kind of leveraging against each other, and then saying yes or no to certain ones, but after a certain period of time. So it would just create a very long process for everyone to find their jobs because this is thousands of people, tens of thousands of people all looking for a job at the very same time, right?
Yes.
So it'd just be a very inefficient way to create a job. The alternative would be just very inefficient.
Yes. It's unique because it's, everyone's ending at the same time. And, this industry really doesn't want to have any hindrances. And, even just like 1 year, 6 months, that could be a huge issue within the global or the American, the national medical infrastructure.
Yeah. Yep. I agree. And
Okay.
costly to say the least.
Yes. And another thing is you're completely taking out bias from it. You can't say, oh, maybe this, you know, student's father is good friends with that medical dean in
You
that
could still
school.
do that. You could
You
still.
can still do that?
Well, I mean, if you think about it, it just means that they interviewed this guy and they put him number one on their list, right?
Oh, got it, got it. So we can still get that
You can still have that.
networking.
You can still have that bias, right? You can still have that nepotism in the field, but it does make it a little bit just more fair in that knowing that like, I mean, it's a little dehumanizing because it falls back to numbers, right? You were ranked a certain number, they ranked you, you ranked them, and then you match at the highest possible ranking that they would rank. Like, like if you didn't match in a program, it's because you were a lower number than other people. That's how it
Yes.
wasn't like it wasn't anything else. It
And that
wasn't
doesn't feel great.
it doesn't feel great in certain ways if you don't match it where you want to be, but it feels great if you do. And so it's better than like, oh, like, having two places and they both like you're just kind of like it kind of just makes you make a decision, right? As well. Kind of,
Yes.
yeah. I don't know. It's certainly a way of doing it, and so I think the way that it's done is efficient and it works. I do think
I will go.
the only thing I don't like about it is like I am like a little bit more of like I do think that the free market does kind of would give a little bit more to certain employees. Like for example, if you're a highly desirable candidate, you can't really have two hospitals compete for you because you know what I'm saying.
Yes.
So you can't negotiate like a higher salary or something like that. And there was actually a lawsuit. Um, I don't know when, but it was like maybe 10 years ago, where someone tried to sue the match because they called it a monopoly. Um, because they were not allowed to negotiate their own salaries, right? Um, they said that this is the only way to get a job through, after medical school. And Congress actually stepped in and just kind of put a kibosh on that lawsuit. That's interesting.
Really?
Yeah, I forget what they did, but they passed a law in order to essentially make the lawsuit go away.
Wow. That is amazing. The medical the medical industry in the US is very regulated.
Yes,
And for good reasons.
for good reasons and some bad reasons, definitely.
Yes. Yes. It's because you and I, we've probably received some world class because healthcare. The US, most people in the US receive world class healthcare. A
Yes.
few a few people uninsured, unfortunately, in order to receive that healthcare, have to pay astronomical prices, and therefore,
Well, I think it's actually different than that. I would say that the average person in Europe, or like let's just say England, gets better healthcare than the average person in America. I would say the top 20% in America probably get better healthcare than the top 20% in
okay, that makes sense.
and I totally made up that number, by the way. I don't know what percentage it is, but I would say like there's a percentage of people that are on the higher side in America that probably get better healthcare.
What do you think that 20% encompasses?
People who have money.
Okay, but I meant on the medical side. Like,
Just how easy it is to see a doctor, how quickly you can see a doctor, the resources to get a surgery when you want it, by elite systems, when things like that. And in general, when you are in the top tier of socioeconomic status, you also have more time to take care of your health as well. So that's another part of it as well.
okay, that is very true. It's wow. And so let's shift gears a bit and talk about your specific field of medicine, your specific field of surgery, orthopedic surgery. What what is it like going into surgery?
It's fun, super fun. It's especially early, it's very nerve-wracking because so I'll tell you a little bit about like the education and training of surgery. It's a lot of it's called pimping in medical school, in which a doctor just kind of asks you a lot of questions about something. So obviously when you first start doing things, it's like a lot of like them just asking you questions or pimping you. So it's like a lot of anatomy questions. You got to know the anatomy. You got to like know indications. You got to know like complications, things like that. So it's a lot of studying for the surgery. So that's like the nerve-wracking part. Is like, oh, I'm gonna totally get asked all these questions like when I go to the surgery. So you try to prepare for it. After like as you kind of go through residency, you kind of get to you got the anatomy down for the most part. You've done the surgery a few times, or like you've watched the surgery a few times. So you kind of know the steps, and you kind of show the doctor or like the surgeon, that the steps, right? So like you anticipate the next instrument that's needed, or you kind of guess what problem that is going to be encountered at this point, things like that. And then eventually you'll get handed the scalpel and like you're able to do the surgery, which is the fun part and the scary part, right? And like it's pretty cool because I think like over the last year, especially from like being a PGY2, so a second year resident, to being a third year resident, uh, like as you reflect over the last year, you kind of see like your surgical skills and your knowledge have like exploded. It's
Wow.
really fun.
You've done a lot of surgeries this last year?
Oh yeah. I'm in the OR 2 to 3 times a week, like just full OR days.
Wow.
But yeah, fundamentally, it's like it's physics and mechanics, really, like orthopedics, right? Like you're using materials to replace things, or you're shifting muscles and tendons in order to have mechanical leverages over certain areas, or you're debriding things, or you're removing things. So it's a lot. It's very complicated, from a small level, like when you're doing it, but from like kind of a macro level, it's actually quite not complicated. It's like you're doing very specific things that are very like, especially when you do them over and over, it just makes a lot of sense on like why you're doing it. And it's nothing special. It's just mechanics.
What do you mean? Like in the sense of a hip joint?
The hip joint is a little bit, well, yeah. So the hip joint. So the reason why you do a hip replacement is because someone has arthritis or pain, or a reason to have pain in the hip and they're older, and so you want to replace it. But like there's certain things that you do, like you want to, like, so this is getting a little like in the weeds of orthopedics, but like for example, you have a cup and a ball. So it's a ball and socket joint, right? So the socket, you want to medialize that into their pelvis. You want to put that kind of as middle as you can while there's still good bone, because the more you medialize it, the more tension you put on certain muscles. So that way you could have a better lever arm for your hip so that way your muscles can have just a greater moment arm. So that way they can control your hip better, right? So like things like that, like why you're doing certain things, it's all physics.
Wow, that sounds like a mechanical engineering problem.
Yeah, pretty much. It's
So
pretty
you
cool
are an engineer.
in certain ways, which is I think probably why I was attracted to orthopedics too.
Okay. Because it's a lot of what do you mean?
It's a lot of like physics to it, and a lot of like like just a lot of it's a lot of physics and chemistry to it. Like even when you're doing a carpal tunnel release that we talked about earlier, it's a conduction block, right? So like you're literally you're decreasing the space for electrical currents to pass through, and so you release it and you allow the electrical currents now to pass. That's what essentially you're doing.
Wow.
You're
And those
increasing you're increasing the cross, it's as though you're increasing the cross area of a wire, right? That current is running through.
Okay. And those wires are the nerves.
Yeah.
Okay. Wow. And you mentioned you use materials. What type of materials do you use?
It depends on the surgery you're doing. So for hips, you could be using like titanium and ceramics. You could use cobalt chrome type of alloys. And then there's like biologics. So there's a lot of like, PRP injections. So like platelet-rich plasma people are using, or like biologics to help people grow or fuse things like that. So it's a lot of different materials.
Wow. And now that you're 3 years in, how do you feel about, orthopedic surgery?
Um, I love it. I think it's really fun. It's like it feels it feels a lot less like medicine than it feels more like a trade, you know.
Yes.
Especially when you do something over and over, it's like just becomes habitual. It's like putting together. It's like people would just talk about like orthopedists are just a bunch of carpenters. It's doing a hip replacement is like same steps every time. There's like not really like a medicine to it. But the medicine does come up on like the other side. Like, how do you control their pain? How do you make sure that they're getting the most optimal care possible? And you have to be able to understand, all of the medicines that they're already on and how that would be affected by the things that you want to put them on, things like that. So there is like medicine to it, but it's a lot less than what you would think a doctor would do.
Okay.
Yeah. So it feels more like a trade than it does it feels like I'm like in an apprenticeship right now,
That's kind of nice.
Yeah, it's fun.
I mean, so a doctor would be more patient facing, more
Or patient
emotion.
patient like giving medications for very specific things. The diagnoses are a little bit harder in medicine. Whereas in orthopedics it can get very complicated. But I'm just saying, like there are certain things that just feel very just mechanical, and a lot less like I need to figure out the diagnosis of this situation. Feels
Okay.
feels a lot less like house. I'm not house with these constellation of symptoms that are super difficult to figure out like what's going on.
Okay.
Because fundamentally, at the end of the day, I could just get an MRI and see what's mechanically wrong with you.
Okay. And then you just do surgery for what's mechanically wrong.
Yeah, depending. Yeah, but yeah.
If it's not necessary, then no.
Yeah. Or there could be other reasons there could be other treatment options without having to do surgery. Surgery should, for the most part, you should try to exhaust non-surgical options before you go through surgery, right?
Yes. And I think that's one nice thing about having a doctor who's on salary versus a doctor who's private.
Yeah, yeah, because they're not going to push you towards that surgery.
No, they're going to make the same amount of money regardless.
Yeah.
Wow.
Yep. And they're not going to offer you like pretty low efficacy things that are high margin, like PRP injections, things like that.
What is the reason that might happen at a private practice?
But money, right? I mean, it's crazy, but like you go to like a lot of boutique places in like Los Angeles or even really anywhere now, or like they'll offer you PRP injections for your knee arthritis, and they pretend like it's going to help you, but it's not. It's not really going to help you. It's just $1,000. It's just $1,000 cash, and they'll take it, and then eventually you're going to need your knee replaced anyways.
And that was just for them to get $1,000.
In my opinion, yes, but a lot of people really swear by it, so I do believe that they believe it, but the data is just not there yet.
Okay, but the data is there for placebo effect.
Yeah, it is, sure, but it's just I might as well inject you with nothing and just not charge you $1,000.
Yes.
Maybe the $1,000 is needed for the placebo effect to kick in.
Yeah, that's it. I think it might be.
Yeah.
Oh man.
But yeah,
well,
I mean, like, and there's a lot of other biologics that people like to do that are just like not low efficacy and like it's just not, the data's not there, but they're able to make a lot of money off of it. I know, like, you're like a big Joe Rogan fan, right?
Yes, he loves stem cells.
I mean, it's nonsensical. The data's not there. His story, he said that he had a rotator cuff tear that just healed after stem cell. I don't even know how that is possible or what that really means, but he just says it did. But I know he had like
Mel
a
Gibson.
get. Yeah, he had a get. I mean, I went through the papers that he was talking about. I mean, it just showed like non-efficacy with things that like are not even gold standard things. So I was just like, I don't know. He's it just wasn't. It was not what he was preaching, and I was just like, this is just nonsense.
What do you mean gold standard?
Well, so like for example, he had like one paper on his web. This guy, I don't know his name, but I remember him talking.
Redorian?
No, it wasn't a doctor. It was some guy who does like biologic injections. And he was talking about how like Wharton jelly was like non-inferior to like other injections into your knee, and he like cited a paper, and I actually went and like looked up the paper, and it was Wharton jelly versus like hyaluronic acid injections. And hyaluronic acid is like injections are these gel injections people get for arthritis. And it showed a non-inferiority to it. What that means is it's just not better than these injections. Okay. But it's much more expensive. Let's just go ahead and say that. And you have to pay cash for it. And it doesn't reverse arthritis. Like you're still going to need your total knee down the line. But this guy was like preaching like as though like it will reverse arthritis. But I think he was very in certain ways, like he was able to be nuanced and kind of suggest it without saying that it wasn't going to reverse arthritis. So that was an interesting part of that conversation.
Wow.
But yeah, so like those things just don't make a lot of sense to me.
What things? When like these very novel bio injectables?
Yeah, I mean the research isn't there, and he is right. So I remember the podcast I was listening to with him, and he was right in saying that often like the research is far ahead of clinical practice, and like I do believe what he said, which is like science progresses one funeral at a time. You kind of have to let like the the old guard kind of pass before like real changes happen in medical establishment. But the facts are the research is not there that these things actually do anything. So PRP injections insert. If anything, PRP has the most evidence for it, but it's really like the research is just all over the place for it. And then like these other biologics that he was talking about, like orange jelly, like that, the research is like it's just not there. So the claims that they were making, just like they're not substantiated yet, and I'm not sure if they ever will be.
People really have to be careful when they hear something on a podcast from someone who's not a doctor.
Yeah. And by the way, this is not medical advice for anybody. I just want to.
No, even if you're a doctor, not medical advice.
Yeah. Yeah. But yeah, like PRP injections, I think is really interesting because there's so many different versions of PRP actually. Depending on how you spin the blood, like do you have a leukocyte-rich platelet-rich plasma? Do you have leukocyte-poor rich platelet-rich plasma? They're getting blood from you. So do you have a lot of platelets? Or you might just be someone who doesn't have a lot of platelets. Or do you have a ton of it? So like they're doing these studies without really defining how much platelets there are or like what kind of PRP is using. And so how do you compare any of these studies? How do you, like they don't even really define it in the study themselves. So you have no idea what they're actually talking about. These are actually different things.
And these studies aren't done in the US, correct?
No, they are. There's a lot of studies in the US now. You could do PRP here.
Can you? Okay.
Yeah, PRP is different. I think what you're talking about is true stem cells.
Okay.
True stem cells, I think that you can't do here. You could. It gets like a little murky here. There's like I don't really know the legality behind what you can and can't study with stem cell stuff, but there are like some things that you can't study here.
Okay, but PRP you can study and you can actually get it injected in the US.
Yeah, for sure. You could get stem cells injected here too. That just certain types of stem cells versus others.
Okay. So you said there's the research isn't there for PRP, but
For PRP, it's the best out of a lot of these biologics, or like for some of these biologics. There are some things that are pretty proven, but like it's really hard to compare the data and to come to conclusions because we just don't know what kind of PRP they're talking about.
okay. So more studies, more research, more well-defined parameters in the studies.
Yeah.
And then maybe we can have an idea.
Yeah.
Okay. What do you
Now,
think
with that being
about
said,
go?
a lot for a lot of these people, I do think that it's probably not harmful, probably, but it is expensive. It's almost like a waste of time. So
How much is it?
a PRP injection, probably like $1,000 for an injection.
Okay.
But it's like, but it's never gonna heal your arthritis.
So it's kind of just I mean, it's your own blood, right? It's your own
Yeah.
plate. Okay. And that's why you say it probably won't do anything negative.
Yeah, it probably won't do anything negative. I mean, there's probably small rates of infection and things like that, but likely not detrimental, but likely not therapeutic.
Okay. Is there any other things in medicine that are going on that kind of have you questioning or, got you like, wow, similar to this PRP and stem cells?
Probably, but I can't think of anything at the top of my head.
Okay. Wow. Well, Hussein, this was a great conversation.
Yeah, awesome.
Thank you so much. Are there any last words that you'd like to leave the audience about, medicine in America or orthopedic surgery?
Yeah, I totally could be totally wrong on a bunch of this stuff, so look it up for yourself.
My guest today has been Hussein Rassoul. Thanks for coming on the podcast, Hussein.
Thank you.